clearly there are conflicting goals of the treatment of the AIS patient when considering surgery. And our goals are deformity correction and maintaining local, regional, and global alignment conflict with the desire to maintain motion and preserve as many motion segments as possible. And now Michelle Marks has shown us that motion is preserved despite fusions into the lumbar spine. But this may come at the expense of caudal disc degeneration, particularly with the increased in vitro disc pressures that we've shown in a cadaver study with fusions to L3 or more caudally, where the remaining discs see much greater loads of with activities of daily living. And Peter Newton has given us the concept of the deformity flexibility quotient. So the concept being less residual deformity with more motion segments gives you a better value compared to more residual deformity and less motion segments preserved. This is Michelle's data showing preservation of motion despite caudal fusion levels. The problem is this comes at excess mobility in the remaining motion segments. And we've shown that at 10 years with a LIV of L4, there's a 27% rate of significant disc degeneration and 10% at L3. So we work very hard to preserve motion segments wherever possible, as in this older case of mine, which we performed a thoracoscopic release and then anterior instrumented fusion, permitting us to fuse to L4, to L3 in this case, rather than to L4. Also, we note that if the lowest instrumented vertebra is shifted or translated off the midline more than 2 centimeters, the rate of disc degeneration at 10 years is much higher. So 2/3 of the patients with an LIV of L4 and 1/3 of patients even with an LIV of L2 or L3 if shifted off the midline. So here, in this case on the left, there's a translation of the LIV, and with that significant disc degeneration compared to this patient in which the LIV is centered well and there is no significant disc degeneration at 10 years. Here's another case. This is an anterior fusion with instrumentation in which we attempted to translate and push the apex over, but we didn't do a good enough job of translating that lowest instrumented vertebra, and this patient is at risk for disc degeneration. So what are the basic tenets of selecting fusion levels, and what do we take into account? Well, the Lengthy classification can serve as a guide, at least in most cases, in which we arthrodese all structural curves, and we may have some rule breakers where we can avoid some of that. The shoulders have to be assessed. If the left shoulder is level or high, we might include the proximal thoracic curvature, even in a non-structural curve. Rotational prominences should be considered. We might consider fusing a non-structural curve in the presence of a large rotational prominence. Leg length inequality can impact the LIV selection, residual non-fused curvature, as well as shoulder balance. And we really want to, in most cases at least, to level the lowest instrumented vertebra and minimize wedged discs below. We need to neutralize the rotation of the LIV and minimize LIV translation, as I noted earlier. Also, preventing junctional kyphosis and adding on. I'll touch on adding on, but I won't discuss junctional kyphosis today. We may fuse a little longer for patients with open triradiate cartilages from the work of Paul Sponseller. I won't spend any time on this today. But really, from the data we showed, L3 is worth fighting for, if you will, compared to a fusion level of L4 when we can do that successfully. So the treatment has evolved, the treatment of scoliosis over decades. And this evolution of technique has also allowed us to evolve our thinking as to where we can minimize fusion and maintain balanced correction. And I would argue that non-fusion techniques will play a role as well in the future and may alter some of our decision making. So early on, the Harrington experience, we fused long, one level above, proximal to the upper end vertebra, 2 levels below typically, and into the Harrington stable zone. And then King and Moe gave us the concept, and they pushed us in the direction of performing selective thoracic fusions, particularly in the false double major or the King type 2 curvature, in which the lumbar curvature is smaller and less rigid, as well as in the other curve types in which fusion can be performed selectively. Now, the Lenke classification has been an excellent guide and has given us a two-dimensional classification of what are structural curves. And there's a lumbar modifier component and a sagittal modifier component to the classification. Essentially, the major curve is the largest curve, as we all know. And the minor curve can be structural if on side bending, the curvature is 25 degrees or greater, or the proximal thoracic curvature is considered structural if the sagittal alignment, T2 to 5, is greater than or equal to 20 degrees, and the thoracolumbar thoracic curvature becomes structural if there's a greater than or equal to 20 degrees kyphosis between T10 and L2. Lumbar modifiers are known to us all. The center sacral vertical line, if it falls within the pedicles, that's a modifier A. If on the concave pedicle, the line goes through the pedicles at the concave apex, that's a B, and C, it falls outside of the concave pedicle. And this can guide some of our decision making. Selective thoracolumbar fusion is also a concept that has come forth and is really desirable in most cases, in which we avoid a longer fusion, including the thoracic spine, as shown nicely in this patient. And I think 3D assessment of the spine will play a role in our selection of fusion levels and our techniques for correction of focal and regional deformity in the future. We've summarized our approach to fusion levels from the literature and our own personal experience with my colleagues, Dr. Errico and Per Trobisch. And that's summarized here in the subsequent slides. So we will fuse to T1 or T2 proximally if we have a structural proximal thoracic curvature as dictated by the Lenke classification. If the left shoulder is level or high, we'll include that often to T2, and we'll include T1 when there is a large T1 tilt. T4 or T3 or T5 even would be our proximal end vertebra for structural main thoracic curvatures, a Lenke 1 curve type without proximal kyphosis. And again, it's important to include the proximal end vertebra. So if that's T3, we're initiating the fusion at T3. Proximal end vertebra is included for Lenke 5 curves, T9, T10, or T11, or even T12, wherever that is. In terms of the Lenke 1 curve type here, we're going to T2 proximally because the left shoulder is slightly elevated or at least level, and in this way we can maintain alignment of the shoulders without throwing that left. Clearly, when there's a structural curvature proximally, we include both curves and fuse down to the stable vertebra in this lumbar B modifier patient. So what is some of the literature on this? We have a 5-year follow-up study in which we looked at selective thoracic fusions. This is a slightly older paper, so the percent corrections maybe are lower than what we're achieving today, but essentially the major curvature, the thoracic curve, is corrected nearly 50%, and spontaneous curve correction of almost 40% occurs in the lumbar spine. And here's an example of that, well done here with a good spontaneous lumbar curve correction. And sometimes there's a residual lumbar curvature that is unsatisfactory, and this can result also, there can be unlevel shoulders. This patient has a leg length inequality, and as we put the shoe lift on the left side and level the pelvis, the lumbar curvature decreases to a more acceptable range, and you can see the shoulders come into alignment as well. So pay attention to the leg length inequality. Lanky 5 curve. So the curvature itself is corrected to a great extent. The thoracolumbar curvature is corrected 66%. And there's less thoracic spontaneous correction compared to the selective. So thoracic spontaneous correction is less. What about fusing Lanky 5 curve selectively versus non-selectively, which we fuse both the thoracic and thoracolumbar curve types? Well, the lumbar curve corrections are similar, whether fused selectively or not, but clearly the thoracic curve is corrected to a greater extent if you include the thoracic curve. However, that's at the expense, as shown here, at decreased range of motion, both flexion, extension, lateral bend, and rotation. So more fusion does have an impact on motion. So we try to avoid doing fusions of both curves. But in this case, the patient had a very significant thoracic rotational prominence. There's an elevation of the shoulder and a fullness in the neck on the right side. So this was fused non-selectively, both curves. And here, on the other hand, a very flexible, mild, relatively mild thoracic curvature, and with a selective anterior fusion, we have a nice result. Anterior surgery has its advantages, known to you all: powerful coronal correction and derotation. Shorter segments can be fused, lower blood loss than the posterior approach, rapid fusion, and the scar perhaps is more acceptable. We've got this data from Harry Schuffelbarger and others. Basically, shorter fusions are permitted by an anterior approach and less caudal, a higher caudal LIV. And here are the scars. So what about LIV selection? Well, for patients with Lenke 1 or Lenke 2 types, for a lumbar modifier A, as shown below, we fuse to the touched vertebra, that is substantially touched by the CSVL. For B's and C's, we'll fuse to the proximal stable vertebra at the thoracolumbar junction. And we would sometimes consider fusing a lumbar curve in a patient with a very large angle of trunk rotation, but we really try to avoid this. And in my practice, favor non-fusion approaches if there's significant deformity in the lumbar spine. Here's a C modifier, stable vertebra is T12, and we fuse to T12 with a very nice balanced correction. Lenke 3s, 4s, 5s, and 6, so structural thoracolumbar lumbar curves, typically will fuse to the Cobb end vertebra distally, but we may add a fusion level if there's significant rotation at that Cobb end vertebra, NASHMO greater than 2. And consider going one short of the Cobb end vertebra, and that's generally L3. If L3 bends to a NASHMO less than or equal to 2 and crosses to the midline on the contralateral bend, as well as the disc opens up on the left side bend, on the bend into the convexity, the disc below opens up. I'll show you that in a moment. We can sometimes save levels by doing anterior releases or anterior approaches. Posterolateral release can be helpful, and I've done this in some patients where we do a T-lift approach and take out a good deal of the disc and some of the annulus. Here are the rules that if we can get the, on the left bend, in this case, NASHMO less than 2 or equal to 2, as in this patient, and the concave disc opens up below L3, and L3 crosses the midline when you bend to the right, that patient can get a fusion to L3, as shown here. What about adding on? That's the distalization of the end vertebra and an increase in Cobb angle of more than 5 degrees following surgery. Can occur proximally as well. And also another definition includes disc angulation of greater than or equal to 5 degrees below the LIV over time. Here's an example on this 10-year-old girl where initially at first direct looked good, and then she's increasing her Cobb angle below. There's distalization of the Cobb end vertebra, and there's wedging of the disc. Larry Lenke has given us the concept of the touched vertebra. I think this is particularly helpful for the lumbar A modifiers, where if you fuse short of the touched vertebra, I think the substantially touched vertebra here is L3. This patient was fused to L2 with adding on occurring. So substantially touched, not just touching a corner of the vertebra. And here, this patient was fused well short of the touched vertebra, and that should have been, and that was subsequently extended down to L4, a large curve. The concept of 1AR and 1AL has to do with the direction of the tilt of L4, and this is important in avoiding adding on. Bianchi and Newton gave us this concept, or have written about this, and you can see illustrated here the 1AR on the right, where L4 is tilted to the right versus to the left. And there is in these patients overall, combining both groups, 1AR and 1AL, 21% in our series developed adding on. And of those, 25% of them were 1AR curves versus 13% of the 1AL curves. So 25% of 1AR curves are at risk. And I think the risk is not fusing long enough in those 1AR. So you're going to tend to want to go one level distal potentially. You want a substantially touched LIV. In this case, that's L2. And this patient was fused to L1 and went on to adding on. And so you don't want to fuse short on the 1ARs. You can sometimes get away with that. And more often than not, you can for a 1AL curve. Here's a patient. I'm not sure we would call this proximal adding on. This patient was fused short of the proximal end vertebra, largely because of the anterior approach, and this is a fairly large curve. You can see suboptimal placement of the proximal screw there, and we fused one level short. And sure enough, she had a progressive curvature above, and this was salvaged 8 years later with extension to fusion proximally, and she had an excellent clinical outcome. Lenke and Bridwell gave us this concept. You can consider a selective fusion if the ratio of the major curvature to minor curvature is greater than 1.2. That includes Cobb angle, apical vertebral translation and apical vertebral rotation. So if those ratios are greater than or equal to 1.2, one can consider a selective fusion, and that would apply to potential rule breakers that don't follow the length classification. So, and we found that we had some rule breakers, and I'm not going to get into all the details for Lenke 3 and Lenke 4 curves, but essentially selective fusions were done in cases in which the lumbar curves tended to be smaller than in the non-selectively fused cases, and that was true for both Lenke 3 and Lenke 4 curves. But if you're going to be a rule breaker, and this is actually a Lenke 1 curve, but the lumbar curve is larger than typically we see, and the Cobb ratio, major to thoracic lumbar curvature, is almost 1.1. So it's perhaps predictable that this case would go on to further progression. So keep in mind those ratios. And here's a rule breaker that we can get away with, despite there being a 50-degree lumbar curvature. Forgive the brightness on the X-ray. It's the best I had. But basically, we did a selective thoracic fusion for this patient with the ratio being 1.26, the flexible curve. And this actually, the patient did very well clinically, as you can see here. So in our selection of levels, it's important to include structural curves, except for the occasional rule breaker. Pay attention to the clinical features of the patient as listed. For lumbar A modifiers, fused to the touched. For B's and C's, fused to the stable at the thoracolumbar junction. That is for Lenke 1 curves and 2s. And for thoracolumbar structural curves, fuse Cobb to Cobb generally. We can save a level at times, particularly with releases in advanced tech.
This was a video of Dr.